All right. Well, good afternoon, everyone. Thank you for bearing with us. We're having a few, how in this new, I don't know, so new, but this world we're in now, there's some technical difficulties every now and then. So we appreciate your patience. We are really, we're going to give it an extra 10 minutes to make sure we are able to fully have this discussion. And I don't know if anyone knows, but I was a policy wonk in a past life. And it's good to have all these policy folks taking the lead on it. On this topic of Medicaid redetermination, disenrollment, and health equity. And I am going to turn it over to, obviously, our future Dr. Mia Keeys. But before that, I just want to make two quick announcements. One, we will have our annual summit on health disparities April 17th and 18th. And so looking forward to seeing you all there, and we'll put a link to registration. Two, a little housekeeping. If you have questions, please put them in the Q&A box below. And if you just kind of want to put your comments or participate a little more actively, go to the chat. And without further ado, I'll send it over to our own advisory board member and past 40 under 40 winner, Mia Keeys.
Really, as always, so very happy to be here, Brandon. Thank you so very much. I'm Mia Keeys, as Brandon mentioned, and I also work for Hologic, the Women's Health and Innovation Company. And you can imagine that for all of us on this call, I too am a policy wonk, as Brandon knows. This conversation is not only timely, but really very necessary as we're approaching the end of the public health emergency period with respect to COVID-19. And so we're talking today about Medicaid redetermination, disenrollment, as well as the impact with respect to and the emphasis on health equity. We have joined with us today Dr. Lydia Isaac, who serves as the Vice President of Health Equity and Policy at the National Urban League. She also holds a joint appointment as faculty at Johns Hopkins Bloomberg School of Public Health. And she's in the past served as an associate research professor through GWU, which is where I am currently in school and pursuing my doctorate. And while she was there, she was executive director of the Robert Wood Johnson Foundation funded Health Policy Research Scholars Program. So I'm really excited for the work that she brings in that space. She's also worked in the past in local as well as state government and academia. So bringing all of that to bear on a conversation on racial and ethnic health disparities, on social determinants, on neighborhood environmental factors, and how all of that matters in the research and policy environment of today. She has received her master's from Harvard School of Public Health and her doctorate at her current place, Johns Hopkins. So thank you so very much for being with us today, Dr. Isaac. We also have with us Ariana Muckerman, who serves as the Senior Director of Health Policy at Centene Corporation. And for those of you who know NMQF, you know that NMQF and Centene work jointly together on many different things toward very common interests to ensure, especially in this conversation, that there's continued emphasis on Medicaid and specifically on Medicaid continuous coverage, which is where Ariana comes in. She leads Centene on cross-product and public health issues in general. And today's conversation, especially focused on the unwinding of Medicaid, particularly in the wake of COVID. She also focuses on interoperability issues, on health equity, as well as behavioral health. And she received her master's in public health from Washington University in St. Louis. Thank you so very much, Ariana, for joining us today, for sure. And then last but certainly not least, we have a true OG in the game, about 2 decades in this game with respect to, not game, but really in this mission work with respect to health and ensuring that people who are protected by class statuses, especially around disabilities, older adults, children in foster homes. We have Jen Dexter, who's here with us as a VP of National Health Council. Jen, thank you so very much for coming. She comes with a background working with National Health Council, as well as its member organizations, to really develop policy positions that help people with chronic conditions, especially in those classes that I've mentioned. But she also just has a true background working with leaders in Congress and as a patient advocate to especially work on Medicaid-based solutions that support the people who she's really very moved to work on. She too has a Washington University connection. So if you didn't know each other before, Ariana and Jen, you'll certainly have to know each other now. So I'm going to just go ahead and very quickly turn it over to each of the panelists. I'd like for you to introduce yourselves a bit more with respect to this work, but I especially want to invite Ariana to talk to us about, what is redetermination policy? What is it? Why does it matter in general? And why does it especially matter now as we are, quote unquote, coming out of the pandemic and really foreseeing the end of the public health emergency?
Yes, thanks, Mia. So for those of you not as familiar, Medicaid redeterminations is something that happens very frequently, at least on an annual basis. Pre-COVID, it happened, at least on an annual basis. The Medicaid population turns on and off coverage very frequently. At the beginning of COVID, so over 3 years ago at this point, that process was halted. And so the Medicaid population has not gone through renewing their coverage in over 3 years. The public health emergency has been renewed in 90-day blocks since March 2020. And then at the end of 2022, the federal legislation, the Consolidated Appropriations Act of 2023, decoupled this continuous coverage requirement in Medicaid from the public health emergency. So starting April 1, in less than 2 weeks, Medicaid beneficiaries can start to lose their coverage. There are over 90 million Medicaid beneficiaries who are going to have to start going through renewing their Medicaid coverage over the next 14-ish months. States are going to determine their timelines. And so this is just an unprecedented caseload of Medicaid beneficiaries who are going to have to renew their coverage with the states. Some of those individuals are going to remain Medicaid eligible. The states are going to auto renew them into Medicaid. This is the ideal state. They're going to maintain their coverage. Many of those individuals are not going to be able to do that. The state's systems are not going to be able to process them. The individuals are going to have to take action to renew their coverage. And some people are no longer eligible for Medicaid. And so that's where us as a managed care organization and others within the industry are really going to have to be educating individuals on the importance of taking steps to figure out either renewing their Medicaid coverage or what other alternative forms of coverage are available to them, either in the marketplace, employer-sponsored insurance, or otherwise. So there are a lot of steps that are needed to be taken. At the state level, there's a huge administrative burden on the states. And so educating individuals about what steps they need to take is extremely important, and having managed care organizations and other community-based organizations being able to alleviate some of that on the states to try to make this as seamless as possible is going to be extremely critical.
I mean, Ariana, you can't overstate just how big of a lift this is. And the fact that you mentioned this is an unprecedented situation, it's not lost upon any of us. The fact that there are going to be people who are going to fall down the cracks, right? And that's what we're really trying to raise in terms of consciousness through this webinar. And I want to bring Dr. Isaac into the conversation to speak to that very point. Dr. Isaac, what does redetermination, and as Ariana has described the process and what the outlook is, what does that matter with respect to equity? And if you wouldn't mind just giving us a working definition of what equity in health means in this particular conversation.
Yeah, thank you. I appreciate it, Amia. So thank you, Ariana, because I think Ariana set a really nice stage to the magnitude of the problem. What I would say CMS, which is the Centers for Medicaid and Medicare Services, is estimating that up to 15 million people could lose eligibility for Medicaid during this process. And this is particularly dire in states that did not expand Medicaid during and under the ACA. So before, there's some states who expanded it during COVID, which was great. They saw the need, but there's many who didn't, and many of those states are in the South. And what we know for equity is a lot of racial and ethnic populations, Latinos, African-American, Native populations, refugee immigrant populations are located in the South. And those are the folks who have been on Medicaid, and particularly what people have to understand that during the public health emergency, I would say we updated or we expanded who could be eligible for Medicaid, right? So we were very much a little bit more generous. And as Ariana said, we also didn't have people redetermined, right, within 3 years. So you're going to have a group of people now who are not eligible for Medicaid because those states did not expand their Medicaid under the ACA. And then it's mostly impacting racial and ethnic populations. And the populations that we know were the most vulnerable during COVID, the ones who were essential workers, and so who had still work and who are still being exposed to to COVID-19. So I also want to say, like, COVID's not over, people, right? And those same groups of people are still the ones that are being the most exposed. Yes, we've done a lot. We've done a lot of great work with vaccines to get people as safe as possible, but those are still the populations that are most vulnerable in this time. And so if they don't have health insurance coverage to get access to, the other thing too, when the public health emergency ends on May 11th, vaccines will no longer be free for everybody, right? So if they do not have coverage, and they need to get vaccinated or they need to get a booster, they may not be covered. So we're also endangering people's health. So that's an equity issue in terms of getting people access to the care that they need to stay healthy and to prevent or reduce the effects of COVID-19 or flu or any other kind of disease that's out there. So what we're really worried about, particularly right now, is that the populations most at risk are the populations that are the most vulnerable. And that's usually Latino, African-American, and immigrant populations that are located in these states that did not expand Medicaid. But the good thing I think that we need to know from, and Ariana made a really good point about what Centene and other organizations can do, is that many of these people will be eligible for ACA. And so knowing where your ACA navigators are, knowing how people can get coverage other places, knowing that they were dropped, that's the other problem too, is that some people may not even know they were dropped from Medicaid, and so think they have coverage and don't have coverage. So educating people about filling out the forms, looking for the letters, making sure their redeterminations have happened, and if they're not eligible, then finding some other source, hopefully, of health insurance on the exchange or some other ways, whether through employment or something else, will help us to think about making sure everybody has a fair access to the care they need. And that is the equity issue here, is everybody having fair access to the health care that they need.
That right there alone is a soundbite. Everyone having fair access to the care that they need, right? Both you and Ariana, Dr. Isaac, have truly set the stage with respect to why this matters, who's getting hit the hardest, and why that will impact everyone, right? But I especially want to bring Jennifer into the conversation to talk about, Jen, you work primarily with people with disabilities. National Health Council also works on behalf of children and older adults. What does all of what Ariana laid out and what Dr. Isaac laid out, what does that mean in terms of your constituency, your organization's constituency, and then what are the key steps that your organization is taking on behalf of the member organizations, to ensure that people are going to maintain coverage and know what's coming?
Thank you, Mia. Absolutely. So as you mentioned, the National Health Council is made up primarily of patient organizations focused on the needs of people with chronic conditions and disabilities. And the Medicaid unwinding is particularly important to that population, because they are more likely to be in need of ongoing care immediately. Somebody who doesn't have an immediate health need may not even realize they're off Medicaid for quite a while. So more of a day-to-day dependence on having access to health coverage that Medicaid provides. Also, Medicaid is the primary source for many people for home and community-based services and long-term care. And that is something that I don't think people quite understand could go away with this. So we're working in twofold, working through our member organizations, which is everybody from the really big patient advocacy organizations like American Lung Cancer, diabetes, those kinds of groups, down to very small rare disease groups, to share information, particularly about patient-based communication. So making sure that we are all sharing information about social media and direct mail and other campaigns that we're undertaking to make sure people know what's coming and what they need to do. And from a health equity point of view, I think it's really important that we are making sure that that information is shared in a broad way. We have a broad base of organizations within membership. For instance, Unidos US has done a tremendous job in putting together a ton of information in Spanish language format, as has CMS, so don't get me wrong, but looking at various populations. And I think the other thing is that this is yet another situation where we need to identify who are the trusted voices in different communities. The patient advocacy community is not the trusted voice, but a trusted voice for many people with that disease, with that issue. After their insurance company, the helpline at the American Diabetes Association may be the second call they make when they run into trouble and need some advice. So we need to make sure that all of those organizations, call centers, are working very hard and have the right information and referring people in the right way, working with industry like Centene and others to make sure there's information back and forth. On top of that, there's an advocacy piece of this, working with CMS, working with Congress, making sure that everything that needs to be in place around monitoring, around identifying issues. We're working very closely with CMS to try and figure out when this starts rolling out and we start getting those calls of people losing their coverage. How are we going to make sure that that's communicated clearly? Because some people are going to need help transitioning because they were appropriately moving off of Medicaid, and that happens, as Ariana said, all the time. People move in and out of Medicaid all the time. But there are going to be a whole lot of people too that run into an issue. Just even in the best case scenario, people are going to miss their mail, people are going to miss their call, they're going to have a bad address. All of these things that we're trying to prevent, but we need to identify those quickly, easily, and get that information out to people who can make a difference about it.
I'll just remind everyone to mute their mics when they're not speaking. And then also to the audience, please listen, give me questions that you'd like for me to weave into the conversation. Drop that below in the Q&A and keep the chat going and flowing to the right or left of your screen, wherever it is landing for you. So for all three of you, each of you is talking about who is essentially at risk, right? And then Jennifer, you brought in this element, this significant point about trusted voices, right? And all of you have alluded to this. Who are those stakeholders that you all are engaging with through your organizations, through your work? Who are those? You've mentioned some of the trusted voices, Jennifer, but if you can each expound on who are the stakeholders, who are the trusted voices, and how through each of your works are you engaging with Medicaid members and people who are potentially not sure about their status moving forward?
I think one of the groups that we are worried about, lack of a better word, we know that one of the most trusted voices are for people with chronic diseases and disabilities, are their providers. It's the nephrologist, the rheumatologist, the person that they see regularly and work with regularly. And that's also where people are going to make that realization that they might have an issue. So that's something we're struggling with, honestly, but we need to identify who those voices are. And I also think we've done so much work, particularly in the vaccine space, around working with non-health community-based organizations on education and outreach. This is going to be another area where we're going to have to rely on those relationships to get information out.
I would say for us, it's definitely providers and pharmacists are two of the big partners, but we're focusing definitely on the provider piece and also understanding that the message needs to be offered through multiple sources, trusted sources, but multiple sources, the same message through multiple modalities and frequently, and understanding that it needs to be offered to the individual and meeting our members where they are. So all of our health plans are very local and have connections with our community-based organizations. So each of them have, you know, a bespoke approach to how they're delivering messages. We do have centralized communications efforts and provider resources and call centers, but also tailored messaging. So some of our health plans are doing things like having people that are available to answer questions in a grocery store or a school where they know that people are going frequently and can be able to offer answers to questions, but then also having the other MCOs get all of the different larger provider groups that have Medicaid patient panels offer the exact same messaging, that the providers are giving that same messaging to all of their patients. Because one thing about this unprecedented time is that everyone across industry, and this is one hopeful point, across industry, across states, regardless of political dynamic, I think are at a very similar goal, is to try to mitigate coverage loss and minimize churn where possible. And so I do think that that similar messaging in multiple touch points is getting out there. So we're trying to get it to multiple sources. But I think the providers and care teams I totally agree with Jennifer there.
Yes, thank you, Ariana and Jennifer. So, you know, at the National Urban League, we are an affiliated network of 92 affiliates in 32 states. And so the thing that I think we also need to recognize here that, because I saw a question in the question and answer, that there's no set date for everybody. We know April 1st, the states can do redetermination, but every state is doing it differently. That's part of the interesting part and the challenge of Medicaid and Medicare, but particularly Medicaid, is that it is a federal program that is administered by the states. And so the reason why states not expanding Medicaid is an issue because they didn't have to, right? And so those states that chose to mandate to expand Medicaid, their requirements are more generous, and so there's going to be less people who are falling off these rolls. But the folks that did not expand Medicaid, they're determining whenever they want, and they could start April 1st. And there's some states that they said are going to start April 2nd, just disenrolling people, right? And there's some states that are trying to do a process that hopefully gives people some time to get their paperwork in, answer the questions. And so to answer the question in the chat, that's part of the problem. There's no set date for every state. Every part of it is knowing what your state is doing. On the other hand, for us, because we have affiliates in 32 of the 50 states, what we've been messaging to our affiliates is that when your clients come in for housing counseling or for workforce development or any other services that we provide, for vaccines, for education, for just help, if it's somebody that looks like even if they don't look like, you can tell by the information because they're getting information, could be Medicaid eligible, letting them know this information. Hey, did you check with this? Did you check with your case manager? Did you check with whoever? Have you looked through to make sure that you're still eligible, or have you looked out for that letter? Because there's some states are sending letters, some people are sending emails, some people are like, every state is also doing it very differently, and the redetermination is very different. And so just making our clients aware that this can happen and that they should be checking, and that if they need help, that we can help them work through the process. And so it is about, I know CMS, I've been on actually some calls with the Centers for Medicaid and Medicare Services. They are trying also to continue getting the word out through different community-based organizations and trusted messengers that folks interact with, so that, as Ariana was saying, they're getting it at multiple touch points. They're hearing it many times and saying, oh, okay, I need to pay attention to this, and I need to make sure that my redetermination is, you know, either going forward or that I'm not disenrolled without my knowledge. And so, you know, but it's a tricky process because it is about making sure that people have to be proactive and informed in this this action, because there are some 8 states who are being proactive, but there's a lot of states who just don't also, and in states' defense, they don't have the capacity. Given the numbers, like Ariana was saying, they don't have the capacity or the ability to notify everybody beforehand, or to make sure that everybody knows. And so there's also a point of, you know, kind of a pressure point on states because that this is happening. On the other hand, they can also just not disenroll people, but that's another conversation we can have another day.
I should add that legislation at the end of the year does put some protections in place. And it's a floor, not a ceiling. But there are some things that states are required to do to help prevent some of this. And I think it's very dependent on states' capacity and infrastructure and how they do it. But we were at least pleased to see that there were some minimum standards set for making sure they have up-to-date phone numbers and addresses and things like that that are really important. So I just wanted to add that to lessen people's anxiety a little bit, but at least that floor is in place.
I have to say,
and CMS,
after you, Ariana.
Oh, I was just going to say, and CMS is definitely taking the authority that Congress gave them, enforcement authority, to heart. The updated contact information that states have to get, the outreaching through multiple modalities in the event of return mail. CMS is working and providing technical assistance with states. They're also requiring the states put in place mitigation strategies if they're not in compliance with all of the different federal requirements for conducting redetermination. So providing that data transfer if someone is no longer eligible for Medicaid, and doing the different checks for their eligibility status. They're doing all of those different steps as they should be, and they're looking at the states and all of their different capabilities. And so I am hopeful that all the different oversights and what you mentioned previously, Jennifer, about like waving the flag when we do see disenrollments happening, or people, those procedural disenrollments, which will occur, happening and people being dropped. CMS is on alert for those. So some of those touch or stop points are in place. And so that is hopeful, but yeah, states also haven't gone through this process in 3 years. So the workforce shortages that they have and the administrative workload that they're gonna have is just another added layer of challenge. So lots of challenges to overcome.
I think we shared in the chat, we've put together a compilation of a lot of the patient advocacy group and other groups of resources around redeterminations, but also all the CMS guidance. So if people want to look in one, and it's in the chat, so if people want to look in one place and see some of the information, if you're looking for a specific state, that would be a place to go.
Mm-hmm.
Yeah, and me not to
please continue.
I just saw it in the question and answer. So CMS, Centers for Medicaid and Medicare Services, they're the federal government that kind of oversees all this. And I didn't mean to sound doom and gloom. I appreciate Jennifer and Ariana come behind me, but yes, and there's also a lot of information that CMS has there. They have a tracker, they have a website for helping you find ACA navigators. There's a bunch of fact sheets on like what to do. And I know in the conversation I've been having, there are a lot of states that have been reaching out to CMS for help. And so I would say the states are not going out there and just saying we want to drop people. It's just that with workforce shortages and with what's happening, it's just the volume is just something they can't handle, that they've never handled before. And so that is really the major problem, is that it just is a lot of people. And then there was a question in the question and answer about, well, what does somebody do if they can't afford ACA? That is actually what the CMS, I've actually been in a meeting with Secretary Becerra, who's the Secretary of Health and Human Services, and that's actually his biggest concern, is that group of people, which we think is going to be between 3 and 5 million people who are not eligible for Medicaid anymore, who will not be able to afford ACA premiums, and therefore will now become uninsured. And we don't have, I'm going to be honest, he doesn't have a good solution for that. We don't, but it is a group that he's worried about, and he's trying to really think strategically about how we support and get those folks covered.
So I will say the chat is, I think it's disabled, it's being worked on. So for everyone who still wants to bring conversation forward, as well as questions, just put it all in the Q&A. We'll manage it on this other end. But all of you are talking to all of the players across the healthcare continuum. I know we have a number of people who themselves are providers, who are on the call. We have people who are patient advocates. We have people who themselves are Medicaid recipients. We have people who are family members of those who are Medicaid recipients or dual eligibles or whomever. So many different people on this call. What is your charge to everyone? And maybe you want to call out specific groups this question is for everyone. What is your charge to our audience in terms of how we can move the needle forward with respect to ensuring that people remain under their insurance? And what are some ways that you want to potentially be encouraging, but also very, very firm with what has to happen? These are thoughtful pauses, but anyone can jump in.
I'll start. I mean, I think this is really, again, the lessons we learned about talking to friends and neighbors. So I think the CMS has developed great communication tools, just simple little, social media posts, messages. Whether you're an organization that has a communications arm and can use your social media platform, your newsletters, all of that to kind of help get the word out, that's really important. But also talking to your friends and neighbors. Just bringing it up, raising that information. If you're an individual advocate, making sure that you're talking to any organization that you're a part of. This is not a health silo information. This is something that should be in the general atmosphere and discussion area. So I would encourage people to do that. If people on the line are providers, I think it's really like doctors or nurses, things like that. I think making sure that those offices, those folks at the pharmacy counters have easy messages that they can share is really critical. It's talk, and then feedback. CMS has asked for hiccups. They want to know, they don't want specific, my Aunt Lucy tried to call and couldn't get through, but what they want is trends. If we're hearing in a specific state, people are hitting snags, and they kind of encourage people to do no wrong door. So work through advocates, work through, public lines, information lines at CMS. There are lots of resources to share that information when people see it.
Ariana or Dr. Isaac, any addition there?
Yeah, I think, Jennifer, I'm going to hit Jennifer's point again. It's education and information and right information. Also we have to be careful that there's people out there who are not giving the right information. So make sure that folks are getting the right information, that they know that that they can still be eligible. That doesn't mean it's automatically just because you have to redetermine that you're not eligible. Redetermine just means re-looking at your documentation to make sure you're still eligible. And I think there's some people who are hearing this redetermination talk and thinking, oh my God, I'm not eligible anymore. They're just going to kick me off, and then don't want to do it because they're scared that they're going to get kicked off. It's actually the exact opposite. It's to make sure, which most of them will be, that you're still eligible so you can stay on. And so just making sure that our communities understand that. And as we said, no wrong door. And we could keep on messaging to people. And I saw something in the Q&A, and to multiple sources. So, even if you're not in health, if you're doing housing work, if you're doing other advocacy work, and you have clients that could possibly be eligible for Medicaid, letting them know to pay attention, and that, please get your paperwork in, or, answer the survey so that you can stay on Medicaid. I look at it as a positive. It's about keeping people on Medicaid and not about disenrolling them. But if they don't put their paperwork in, then they won't get to stay.
When's the deadline?
It
changes. You answered that earlier, right? It depends on the state, right?
Yeah.
So for the person who raised that question, oh, please, Ariana.
Oh, I was just going to say, and I mean, it's cyclical. So one of the challenges, and that we're, you're towing this line of wanting to provide the education and also not cause panic. So some states are not starting disenrollments until July, but the individual may not go through the renewal process until December. So they need to be updating their contact information, but they may not have to fill out renewal forms until later in the fall. So it's education and awareness about kind of the process as a whole is extremely important. So education and understanding, I think, is totally critical, and having the no wrong door and also completeness of the information is important. There's also a 90-day reconsideration period in Medicaid. So if somebody did get disenrolled and is still eligible, and then they go to the pharmacy and they get denied because their coverage did lapse, and they're within that 90-day period, they can get renewed in a faster sequence, and they can get renewed faster back onto their coverage. So there are some also hopeful pieces to it, where if somebody is using coverage, they could get back onto coverage. So there is a lot of nuances, and I totally agree on the not thinking of it as a disenrollment piece. Most individuals are going to be renewed back onto Medicaid as opposed to being ushered to alternative coverage. So I think having all those different stakeholders having the information and having the completeness of the information is going to be really critical, and knowing where to send people to. I probably got irrationally excited. I filled a prescription and I saw like signs like, are you Medicaid or CHIP beneficiary? You may need to renew your coverage. And, just having something like that, that's a helpful reminder, and directing someone to Medicaid.gov and directing someone to the state, and just where they can call and get some information and talk through the process, get their contact information, know that they're going to be receiving forms and read through the forms. It's helpful to understand that they're going to have to be going through a process, but not having that contact information and not receiving that information in the first place is going to be a huge hurdle.
So for that 90-day period, Ariana, you mentioned of reconsideration. Say, for instance, someone presented for care and maybe they didn't know that they needed to redetermine their status, or their redetermination had not yet been processed, right? Will they receive a bill for presenting for care?
It probably depends on which tier of Medicaid, and we can probably get you some additional information on that, but it should get sent to their former coverage, is my understanding, but we can follow up with some additional information on that. I think it depends on which tier of Medicaid they were covered on.
Mm-hmm. That's also my understanding. I wanted to ask each of you, so in March of 2020, which for the US, many people consider that to be the start of COVID-19, right? In earnest, right? That's when companies shut their doors for the most part. That's when remote work became pretty much the standard for so many different people, right? We also saw by starting certainly in March, but really by the end of that year, reports of, to get back to those who have been impacted the most during COVID, we saw reports of, for instance, Navajo Nation being hit the hardest, more so than any other state across the nation, being hit with the highest infection rates with respect to COVID-19 for so many reasons, right? And many of those reasons, of course, predate COVID and have everything to do with social determinants of health. Knowing that, and knowing about Medicaid rates amongst American Indians and Alaska Natives, what are some truly thoughtful and significant strategies that either your organizations are uplifting to ensure that particularly American Indians and Alaska Natives are receiving information that's necessary, but then also our partners in ensuring that the message is being sent? What are you seeing, and what should work and what hasn't worked in the past? Or if there are organizations that you see have been doing really great work with American Indians and Alaska Natives prior to COVID and certainly during, let's uplift their names in this space as well.
I'll take the first stab at it in that, I think particularly what worked, there was another question in the chat, I'm going to tie them both in together. What worked particularly well in during the COVID-19 pandemic, and it's something you said, I think Mia, you said earlier, or it might have been Jennifer, I can't remember, but saying about meeting people where they're at. And I think sometimes we, and that was a lesson that we learned that we used also in our communities, is that sometimes we just think, oh, if we put it on social media, oh, if we make a flyer, oh, if we tell people to go to a website, they'll know. And, you know, there's lots of people for many reasons who don't know. They're either elderly and are not connecting with the internet and the web that way. They don't have broadband access, so they're not able to connect with high speed ways. There's literacy issues, both not only in different languages, but also just level of people's health literacy. And so one of the things I don't know the organization's name, and I apologize, I know that happened during with the Navajo Nation, when they started realizing how bad their rates were, is that they organized within themselves, and a group came up and started doing some navigation work. And they basically used community health workers to come in, and, you know, also because there's a trust issue, rightfully so, particularly on reservations. You know, the other thing with, if you're talking about Native Americans on reservations, their healthcare is through the Indian Health Service. It's not through, so that's another barrier that they have to deal with. And so we saw some really great programs that came through where folks organize themselves and use community health workers to go out to particularly those nations that are in rural areas that the Indian Health Service doesn't have as much of a reach, and did some one-on-one going to folks' home and saying, hey, how are you feeling? What do you need? Can I get you vaccinated? What questions can I answer? And what we learned from the COVID-19 pandemic and working with our communities, we also had community health navigators, was that it takes a lot of conversations. One conversation is not enough. Sometimes it takes up to 17 conversations for people to really either change their mind or get informed the way they did. So I think Jennifer's point of constant, and Ariana's point of, we have to get this message out there, but we have to meet people where they are. We have to understand that people are scared and don't understand knowledge always the way that we did. And we have to talk about it in different ways, coming from different angles, using different language to help inform people so they can make the best decision for themselves. So it's really about getting out there in the community and not just sitting on a perch somewhere and thinking like, okay, we can just put it out on social media and they'll know. That's just not how it happens. And particularly in vulnerable communities, I think particularly in communities that may be isolated. I think we also have to think about Native populations that they're not just on our reservations. Actually, cities have some of the biggest populations of particularly Native American populations. And so making sure that our urban centers understand that this is a population that they have to reach in a very different way, that you can't just say, oh, we're just going to go to reservations and that's where they are. That's actually not true. New York City has one of the largest populations of Native people in the country. And so we have to make extra efforts in our urban centers to reach our Native folks. And then, you know, Alaska Natives and, folks indigenous to Hawaii is a separate kind of outreach, but there's a cultural outreach that has to happen in those communities also.
But yeah, I totally agree. I think you guys are a great example. Like, if you talk about Urban League, you don't immediately think healthcare. You think lots of, it's one of many issues. And I think that there is a need to really engage some of the more kind of just community advocacy-based organizations in healthcare broadly. This is a great opportunity. Vaccinations were a great opportunity to develop those relationships and keep them going long-term. Don't drop in, drop out. It doesn't work that way. You're absolutely right, Lydia. And I also think that there is an opportunity here with a younger generation who I think in some ways is much more engaged in identity politics, kind of, of understanding who they are, not necessarily for themselves, but to be advocates and talk to their family members, their, aunts and grandparents and all of that, to be the voices to get the word out there, using organizations that are advocates for different communities that younger people might be more connected to, I think is a good thing.
I really appreciate people in the chat are uplifting the names of the organizations that had been helpful on the ground. So CORE, the community organized relief effort, was certainly involved in a lot of that, what Dr. Isaac was talking about, and other organizations that someone else lifted in the chat. I want to ask you all a couple more questions, and then we're going to have some closing remarks. We've talked about this from the patient perspective. We've mentioned this from the provider perspective. We have members of the audience who are themselves representative of industry. Why does this matter? What are the services that you envision really being hit hardest with respect to redetermination, and what are some things that you might want to say to members who are thinking about it to audience members who are thinking about it from that perspective?
In terms of what Medicaid services might be most affected? Wow. All of them. It's a hard answer, because when you lose service, I think one of the things that is important in all of this and in the communication piece is understanding what services are Medicaid. I think there's a lot of people out there who don't know they're on Medicaid, honestly. Even down to like, oh, I'm on, Buckeye Care or whatever it's called in Ohio, or, those kinds of things. So making sure they even understand that. And I think then as people who are transitioning off Medicaid, the difference between what they might have in Medicaid and what they might have once they move to a plan through the ACA with subsidies that might cost them the same, might be, still be no premium for them. What they get, the difference between what's covered under Medicaid and what isn't, I think kind of understanding that is tough. The lack of coverage for home and community-based services and long-term care and those kinds of things. So.
Yeah, that's literally the answer to that question. Everybody is impacted by this conversation, right? That's the hardest part. There are major takeaways, I imagine, that each of you are thinking about. As you said, redetermination is nothing new. It happens all the time, except for these last 3 years where, it's just been extended on account of the public health emergency. But what are some takeaways, some lessons that each of you anticipate from this unwinding process that could potentially be thought about in terms of long-term improvement?
So a couple of things. Well, one thing I just wanted to mention, and this won't be the case in all cases, but the enhanced subsidies that at least now are going through 2025, and we're hopeful will be made permanent, will hopefully offset some of the cost sharing on the exchange. So some of the Medicaid beneficiaries who may become exchange eligible could qualify for those enhanced premium tax credits. So that's one thing that I think, just based on what you were just saying, Jennifer, I think goes to navigators and other, back to what you were saying, needing to have a whole understanding of the complete picture of what is needed and what people are going to be qualified for in the education piece. But in the long-term sense, I think we've touched on a lot about what CMS is doing to improve state systems and mitigate coverage loss by transferring eligibility status and trying to improve how renewal processes work. And there's a lot of work to understand and improve the enrollment and eligibility process, how we're collecting contact information, conducting outreach. And this is industry-wide. This is not specific to insurance or states. This is across the board in the industry broadly. And so I think that there's just a lot of hope on our end that this is going to be long-term improvements to help streamline how individuals are learning about seeking out coverage, maintaining coverage, conducting enrollment and eligibility processes, and being able to maintain coverage. So I think there's a lot of improvements that are going to be made and learnings that will happen during this process, and hopefully be improved upon during the process, and then momentum that will be maintained throughout.
It's not lost upon me that you use the word hope twice now, Ariana, which I love. Go ahead, Jennifer.
That's full Friday.
There we go.
I totally agree with you, Ariana. I think this is as painful and as hard and as big a lift that this is going to be, and as many hiccups as there are going to be. In a good case scenario, we come out of the other side of this with a Medicaid system that is just a little bit better. I mean, getting that communication and getting everybody's addresses and phone numbers and communication channels right, that people are working on right now in such a hard way will serve the system well in the long run if they can keep it up and keep going. That's something that's always a struggle for states. And I agree with you, Ariana. The improvements and the practice and experience we'll have with moving people between Medicaid and other coverage options with assistance will help. People move, particularly, there's a big part of the population that moves in and off of Medicaid all the time. I mean, that's just, you're on that edge of the income eligibility. You move back and forth depending on, your year, you got a job, you didn't get a job. We need to get better about helping those people, making sure they don't have gaps in coverage and that they're appropriately getting the support they need. And this will help that. So that's an opportunity too.
So I'll ditto everything. And I also think it's a great opportunity to have states rethink how they do things. But also, as I said before, I've just been in conversations with CMS, and it's also having some states rethink if they don't want to expand Medicaid, right? And so I think this, as painful as it's going to be, it is going to make some states say, you know what? Maybe we might want to consider expanding Medicaid just a little, even if not the same way that other states are, to help these populations. And we're seeing it. It's been put on ballots. People are voting for it. And so, hopefully, I'm going to use the hope word again, out of the pain, like a phoenix we rise, like comes some really great kind of resources and changes for populations that are most vulnerable. And that's my hope, even in this painful period.
I too am hopeful, and I'll keep that trend going. But you're absolutely right. I mean, we've recently seen the state of North Carolina's expanded Medicaid, right? And hopefully that trend is not going to slow. Especially like you said, because of what's happening as we approach the end of the public health emergency. One of the things, Jennifer, I was thinking about what you mentioned earlier about people not necessarily thinking on its head about an organization like the National Urban League being really a health-oriented organization, right? And it gets me to thinking back to the 1960s, before Medicare and Medicaid had even been ratified into law. It was up to organizations like the National Urban League leaders, at least those who helped to push health and health equity and health disparities as a civil rights and health, healthcare as a right, as a civil rights movement core strategy, right? So I bring that up to say, 1965 was when Medicaid was, became the milestone for the nation's health insurance plan, right? For the indigent and those who had previously not been covered, but it's had to really live so many lives since 1965. Who could have ever anticipated a major pandemic like COVID-19 after the 1918 influenza, or the 2014 Ebola crisis, which was more like an epidemic as opposed to a pandemic, and so many other tuberculosis in the early 1900s. All of these other things that Medicaid and the civil rights leaders and the patient advocates and the congressional champions, none of them could have anticipated what we'd be looking at today in terms of the healthcare needs of a nation that is increasingly diverse, racially and ethnically so. Age, people are living for a lot longer, because that's a point too. People who established Medicare and Medicaid weren't necessarily, and Social Security weren't necessarily thinking about people living as long, right? I promise this diatribe is going somewhere. My question to you is, what does this mean if we were to be talking about Medicare and Medicaid 20 years from now, 50 years from now, 100 years from now? What is your vision in terms of takeaways from this moment that we don't want to have, we don't want to see still living in the future, but we need to see grow in terms of how Medicaid serves us as a nation? Big hopeful question.
I mean, I think really it's the same thing that we've had happening over the last several years after the ACA, after living through a pandemic, all of these things, I think we're learning more and more as a nation around the bedrock importance of access to healthcare in an affordable, accessible way. And we need to have all of the pieces in place. So I think what we're seeing is the importance of not having the gaps that we have now, of people who are falling through the cracks or not covered. And we need to kind of commit to working together to making sure that we are kind of completing the puzzle. We are making sure we're filling in all those missing pieces in whatever way makes the most sense, whether it's subsidies for ACA coverage, whether it's expanding Medicaid, whether it's, you know, making sure Medicare is complete and complex for people with all sorts of needs. The spotlight has been shown on the need. We still have a long way to go to meet that goal, but I think we're making progress.
I think the pandemic shed light on what I'm guessing that everyone on this call already knew existed, and existing health disparities and health inequities, and then just exacerbated them. And so I'm hoping that the momentum of the healthcare industry to help improve and try to close coverage gaps, try to mitigate health inequities, and attention to health inequities broadly, whether it is increasing access to affordable and quality care, or looking more broadly in things like coverage challenges in certain geographic areas, or housing, or insecurities in different aspects beyond healthcare, and how all of those intersections feed into things, including health. I think that momentum is strong coming out of the pandemic. And so I'm hopeful that this is just kind of the first steps, that moving forward out of the pandemic, looking ahead 10, 50, 100 years from now, we'll be able to look back and see a lot of progress made from learnings that, you know, we had from this period in time.
So Mia's trying to get me in trouble on a national webinar, but that's okay, because I'm going to say it anyway. If you're talking 20, 50, 100 years out, I think what the pandemic has showed us, and I think what this process right now is showing us, is that we need to make sure everybody's covered. And a way to get everybody covered is some type of universal health care. So I'm going to say it. I know people don't like to hear it. I'm going to say it. I'm going to get in trouble for it, and it's okay. And that doesn't mean that it has to be government sponsored.
No, it doesn't.
But it means that everybody, we saw particularly in the pandemic, as people were losing jobs and losing their coverage and then getting sick. That was the wonderful thing about the way the federal government actually expanded determination for Medicaid, is to get people quickly onto Medicaid who lost jobs, because normally it takes you have to use the last year's W-2s and all this other stuff, but they made exceptions if you could prove that you lost coverage, blah blah blah, all that stuff. They got people on Medicaid really quick, and that was really important for saving people's lives, particularly early when we did not have vaccines. And so if we're really talking about equity and making sure that people have fair access and they can support their health in the way they need, we need to not have people lose coverage, period. And the way to do that is some sort of universal coverage. However we organize it, that's fine, but we shouldn't be having this issue where people are worried that we're going to have 5 million people that may not have any kind of coverage. That's 100 years from now. I'm not talking about tomorrow. I know that's not going to happen tomorrow. I'm realistic. But I do think if we're going to learn a lesson 20, 50, 100 years from now, that's the lesson we need to learn.
These are hard lessons to learn, and certainly harder topics to discuss, but I'm so very grateful to be really filling this space with you all in this historical moment. And I'm so proud of the work that each of you stands for and are pursuing in your individual roles, but then also as a collective part in bringing your work to this collective conversation through the National Minority Equality Forum. I'm going to ask you all to just give 30-second closing remarks if you have any, and then I will remind those who are still a part of the live audience here and those who are going to watch in the future, this is recorded. And so you can come back and engage with this over and over again. The transcript should be available via the NMQF YouTube channel, if I'm not mistaken. But let me go ahead and open this up. Jennifer Dexter, VP Policy, National Health Council. Closing remarks from you, please.
Just thank you so much. I think the more we have these conversations, the more people we engage, the more diverse and interesting partnerships we develop to get the word out around this and other health issues, the better we'll be. So thank you so much for having us.
Thank you for being here. Ariana Muckerman, Senior Director of Health Policy at Centene Corporation.
Yep, thank you for having me. Our healthcare system is highly complex, and so helping to navigate it and ensure people are not losing coverage and can maintain access is going to be critical. So thank you all for delivering that message.
Really appreciate you breaking it down the way you have today. And last but not least, Dr. Lydia Isaac, VP of Health Policy, Health Equity and Policy at the National Urban League.
I would just say meet our communities where they are. Make sure that you're giving people information in ways that they understand and that it's resonating with them, and that we don't all have to be an expert on everything. You know, I saw the conversation about American Indians and Native Americans and Alaska Natives. I'm not from that community. I can't say the best thing for that community, but we have folks on the call who are from that community who can help us to partner and learn more. So just remember, partnerships, meeting people where they are, communicating with our communities as much as possible to help them get access to whatever it is that they need to live a healthy life.
And I will ditto all three of the participants of the panelist conversation. I'll also remind you all to make sure to tune in to NMQF's Friday conversations, but then also register for the Health Leadership Summit, which is coming up, as Brennan mentioned at the top of the call, on April 17th and 18th. And for those of you who want more information, just visit the NMQF website. I will certainly be there as I try to be there all the time. I'm Mia Keys, and with Hologic, I serve as the Director of Health of Government Affairs, and I'm always going to be available to NMQF to uplift important conversations like this. So thank you once again to everyone, to the audience. Hope you all have a great weekend.